So to lead the next session, we have Dr. Wilson with us. Dr. Wilson has completed his BSMS and MD from the Government Siddha Medical College, Chennai, and he has an extensive research and teaching experience. At present, he is he's working as a research officer at the Central Council for Research in Sidhha. And to briefly mention about his research experience, Sir has worked as Siddha's physician in Health India Foundation and clinician for the DST sponsored project entitled Efficacy and Safety Evaluation of Siddha Herbal HIVs 2004 for HIV AIDS at Jawaharlal Nehru Center for Advanced Scientific Research and Vedic Remedies, Bangalore, in formulating the Siddha clinical protocols, counseling and recruiting the volunteers for the study, and managing any clinical complications encountered. And he has also worked as guest Wissel Schäffler, Department of Complementary and Integrative Medicine at Germany. Over to you, sir.
At the outset, I would like to thank my Director General, Professor Dr. N.J. Muthukumar, for giving me this opportunity to deliver this orientation lecture. And also, I thank Central Health Education Bureau for giving this opportunity, and as well as Ayush Vertical, DGHS, Ministry of Health and Family Welfare, Government of India. So this will be my outline of the lecture. First a preamble, and followed by that the components of the SDGs for what you have already listening to. So I would like to start my lecture with this quote. This is not of my own. This is taken from the technology think tank, Ministry of Health, Ministry of Science and Technology, Government of India. So in 2000 BC, they were saying that eat this root. And in 1000 AD, they said that root is heathen, it is uncivilized. And they said, say this prayer. And in 1865 AD, they said that prayer is a superstition. Drink this potion. Potion is nothing but our decoction. And in 1935, they said that potion is bad, swallow this pill. With the advent of modern medicine, swallow this pill. And in 1975 AD, they said that pill is ineffective, take this antibiotic. And coming back to 2000 AD, they say that antibiotic is poison and we are back to square one, eat this root. So this emphasizes the importance of Ayush Vertical, DGHS, taking this important initiative in formulating the standard treatment guidelines. It's not the Ministry of Ayush or our council or the our Directorate of Indian Medicines. The Ayush Vertical from Directorate DGHS, Ministry of Health and Family Welfare, has taken this important initiative, emphasizing the need of our traditional systems to overcome. Nowadays, we often, the pediatricians, for example, they don't easily prescribe antibiotics. There was a time when then and there they treated with antibiotics. Now they, even only after 3 days of fever, they evaluate and start, and say the probiotics have gained wide importance, which was a very good concept, age-old concept, ancient concept mentioned in our Siddha system of medicine. So Madam also mentioned about gut, which is the second brain. And to emphasize this point, even we don't avoid broiler chickens because they are fed with antibiotics. So such is the importance we are living this era, and we have to take it forward to bring about a paradigm shift. Okay, this is a difference between research in conventional medicine and Ayush. Normally, in drug development, they start with in silico studies, then they do the in silico means computer modeling, and they do the in silico and in vitro. In vitro in cell lines they do it, and in vivo studies. Then they come to clinical phase 1, phase 2, phase 3, phase 4. But in Siddha system of medicine, we go back from clinical practice, we go back to finding the exact mechanism of action. So we do a reverse pharmacology approach. So the difference between research in conventional medicine and Ayush is listed here. So the conventional medicine is widely evaluated before availability. Standards are often available. Academic research structure is there. Public and industry funding. So the main thing behind this industry funding. They are pumping lot of money. Um, the retired Vice Chancellor of Manipal University, Professor B.M. Hegde would tell that the pharmaceutical companies are creating customers, not cures. So they have shares in their own company, and many even reports are even doctored. So the pharmaceutical companies are creating customers, not cures. So such is the era what we are living with, where lot of money is pumped into from the industry, and research motivation is improvement. But in the case of Ayush, Siddha, evaluation only if we have it is frequently used. We have diversification, tailor-made approaches which are unique to our system. So tailor-made approach is very unique to our system. Now the academic research structure is improving after the support sufficient funding from the government of India, and research motivation is justification. For example, in the case of Kabasura Kunnir, so we did many studies when we faced with the pandemic only. For example, in JIMS Noida, we did a double-blind placebo control trial. So one group was given Nilavembu Kunnir, one group was given Kabasura Kunnir, and the placebo control was decaffeinated tea. So such is the thing I want to highlight before going to the topic. So why this DGHS has given this thrust? So India presently is the largest populated nation. So such much population, so 145 crore people, and this is approximately the combined population of 6 countries. Say for example USA, Indonesia, Brazil, Pakistan, Bangladesh, Japan. See that much we are populated, and with large human resource base comes many inherent challenges. And India is bearing the dual burden of diseases, where on the lower end we have malnutrition. So obesity is also stated as malnutrition, hygiene, immunization, sanitation, and infectious disease were the major concerns. And on the higher end, environmental health and lifestyle diseases and other non-communicable diseases have raised alarm. So we are discussing from morning about the metabolic diseases. So in other words, we can say that India is facing a triple burden of diseases. So unfinished agenda of communicable diseases, non-communicable diseases. So namely heart disease, cancer, diabetes, and chronic pulmonary disease contribute nearly 8 out of all deaths due to NCDs. So if there are 10 people dying, 8 people died due to this. So that much importance, and they all share 4 common risk factors, namely tobacco use, harmful use of alcohol, unhealthy diet, and lack of physical activities. This unhealthy diet and lack of physical activities, from our UG, we are learning that both this two contributes to every disease. So if we can impart to the patient what to eat and what to do, do's and don'ts, and we can counsel the patient to avoid tobacco and harmful use of alcohol, we can prevent 80% of the deaths. We can prevent 80% of the deaths. Leave alone the medicine. If this we can teach the patients, that much we can come up with. So, as you all know, Siddha is a holistic system of medicine. So, comprehensive, we don't treat in, by symptoms. We take the patient as a whole, and first comes lifestyle advice. With that, internal therapies, diet regimen. Before that, we have a proper diagnosis. So, even in ICD-11, there are many diseases which are classified as idiopathic. We are living in 2025. So, all the sophisticated equipment, instrumentation is there. Lot of biomarkers, PET scans, even though the primary etiology is yet to be found. In ICD-11, you find lot of things which are idiopathic. And with our our Vadiyadal IM, we will be able to identify the root cause and treat them effectively along with external therapies. So, counseling, it's a special art. So, we are equipped. So, hope is grief's best music. So, we can give hope to the patient. And normally, our allopathy counterparts, they are overloaded with patients. They don't have even time to talk or touch the patients or even observe the signs. They depend only on the laboratory values. But whereas we can have time to interact with patients, which can make a big impact. Lifestyle modification. So, we have to educate each and every patient. And dietetics, diet and nutrition. So, nowadays in Arogya stalls, we have this stall, Ayurveda Ahar. It's everywhere popular now. So, lot of emphasis thrust is given to diet and nutrition. Yoga. So, our expert Dr. Vetrivendan is here. Apt medications, and depending upon body constitution, symptoms, age, and their occupation, single or polyherbal formulations used, we can give a precision medicine. So, we can directly address the issue. So, coming to the dyslipidemia, we all know it's a disorders of lipoprotein metabolism resulting in high total cholesterol, low density lipoprotein, as madam has elaborately dealt that, and non-high density lipoprotein cholesterol and triglycerides. So, what is non-HDL? So, non-HDL is the difference. If you subtract the total cholesterol from the HDL cholesterol, what you get is the non-high density lipoprotein, non-HDL cholesterol. So, the signs and symptoms as described in Korupu Migu Gunam, a condition of excess fat such as increased fatty tissue, fatigue, dyspnea or on exertion, excess muscle formation in buttocks, genitals, chest, abdomen and thighs. This is what our literature says about Korupu Migu Gunam. So, the global prevalence according to a WHO report states that males were affected 40% and females were affected 37%. So, the recent prevalence estimates say that in India 10 to 15 in a rural area and 25 to 30% in urban populations have dyslipidemia. So, 1 in 4 patients have this problem, and the prevalence rate of dyslipidemia in India based on total cholesterol, if it is more than 200 milligram, in 25 to 30, the prevalence rate is 25 to 30%. Non-HDL cholesterol. So, the difference between total cholesterol minus HDL is the non-HDL cholesterol. So, if it is more than 160 milligram, so that prevalence is also 25 to 30%, and LDL cholesterol more than 130 milligram. So, 1 in 4 persons are it's prevalent, and non-HDL cholesterol more than equal to or more than 130 milligram is 50 to 55% of patients. So, 1 in 2 have this non-HDL cholesterol of more than 130, and LDL cholesterol 100 milligram, more than 100 milligram, so 50 to 55 patients. So 1 in 2 patients have this, and triglycerides more than 150. So 30 to 40% of the patients have this, and low HDL cholesterol. So 60 to 70%. So nearly every other individual is a risk of having low HDL cholesterol. So the major risk factor is cardiovascular disease. So people don't understand the seriousness of this issue. Elevated LDL is a significant contributor to atherosclerotic cardiovascular disease, while some studies had shown that non-HDL protects HDL cholesterol predicts cardiovascular risk better than LDL cholesterol. So the difference between total cholesterol minus HDL is the non-HDL cholesterol. So it's more indicative of a cardiovascular risk better than LDL cholesterol. So the nowadays we see higher prevalence in most south and few North Indian states, more in urban and rural areas. So this is the Sidhha pathophysiology. So whatever I said in my introductory slides, so the dietary habits and the lifestyle, diet and activity, and hereditary stress and intoxication. Intoxication comes from smoking, alcohol. So proportional changes, it's lead to proportional changes in primordial elements in the fundamental tissues of the body. So it increases the fat adipose tissue, and further with the paravocal we have circulatory disturbances, and with the more adult, so the digestive fire is affected, and again we have this disturbance in the vayu for circulation and digestive fire affected, so leading to inflammation of intimal layer of vessels and reduces the elasticity of vessels. So the our pathophysiology, it is true that whatever our Siddhas have said. So clinical presentation, we have yellowish fat deposits visible on the skin, xanthomas, and arcus senilis ring in the cornea, and lipemia retinal. So it is visible on retinal examination, and lower limb ischemia, angina, transient ischemic attacks and strokes. It may also present as a non-alcoholic fatty liver disease. So secondary cause, hypothyroidism, nephrotic syndrome, biliary obstruction, hematoma, pregnancy, and in various drugs, oral estrogens, glucocorticoids, and thiazide diuretics, and alcohol abuse. So again and again we are repeatedly hearing, and patients sometimes even don't wish to disclose their abuse pattern, and obesity, Niemann-Pick disease, Ullmann's disease, and cerebroteteinous xanthomatosis. So these three are genetic disorders. So differential diagnosis in Siddha medicine is obesity and ஐயம் மிகு குணம் and வளர்ச்சிதை மாற்ற நோய்கள். So metabolic syndrome. So we all know that we have ordered fasting lipid profile for many patients, and the National Cholesterol Education Program provides the adult treatment panel, and it recommends that for persons in 20 years of age, it should be done once in 5 years. But if the person is less than 20 years also, and they have a family history of dyslipidemia, then we should consider checking younger patients also. So this is the classification of weight by body mass index in adult Asians. The above shows the classification, WHO's classification, where we have obese class 1 and class 2, class 3. but in our adult Asians, the classification is obese 1 and obese 2, where the BMI, if it is more than 25, it is not good. So advanced investigations, what should be done? It is there in our STGs. So apolipoprotein B, apolipoprotein A1, lipoprotein A, terminal test, high sensitivity CRP, glycosylated hemoglobin, fasting blood glucose, thyroid stimulating hormone level, liver function test, serum creatinine, creatinine kinase, urine analysis, homocysteine levels, fundoscopy, waist tip ratio, waist circumference, skin fold thickness, plasma leptin, upper abdominal ultrasound. So this is the diagnostic criteria based on the lipid profile, fasting lipid profile, and if the mild to moderate risk, it is stated that if total cholesterol is more than 200 to 239, we are said to be in risk, or LDL cholesterol more than 30 to 194, or if triglycerides is 175 to 499, or high HDL cholesterol if it is less than 25 to 35. So it is categorized as mild to moderate risk, and the severe risk group is categorized if total cholesterol exceeds 240 milligram, and the LDL cholesterol if it is equal or more than 194, and triglycerides if it is more than 499, and if HDL cholesterol is less than 25 mg, they come under severe risk category. So the classification is primary due to genetic mutations, can be inherited as an autosomal dominant, autosomal recessive or X-linked, and secondary improper lifestyle. So again we come to the same point, physical lack of physical activity, unhealthy food habits. So in the younger generation we find erratic food habits and alcohol intake, smoking. So these four are repeatedly stated for all metabolic disorders and by some health conditions such as obesity, hypothyroidism, diabetes, chronic kidney disease and liver disease. So this is our N-Vagai Thervu, and based on comorbidities there could be changes in it. So the Naikuri states that like Muttupol Nindidil Kabam, so pearl and disappears as a ring, and Nadi Adalayam or Ayaral, or it can also be Kabavadam or Kabapitam. So the red flag signs are early stage of onset for coronary artery disease in by itself or in family includes heart attack, stent or a CABG done earlier. So we should be dealing them appropriately, and recurrent vascular events and atherosclerotic cardiovascular diseases with genetic dyslipidemia, and clinical evidence of atherosclerotic cardiovascular coronary artery disease is itself a red flag sign, and if it is occurs in other vascular beds like peripheral artery disease and heterozygous familial hypercholesteremia, or coronary imaging shows more than 50% of the lesion in two major vessels, and total cholesterol if it is more than 220 or LDL cholesterol more than 190 in individual itself, it's a red flag sign, and tendon xanthomas and uncontrolled comorbidities. So these are all red flag signs we should be aware of, and this is the algorithm which will be dealing now. So before management, prevention comes into play. So regular screening for individuals with family history or risk factors. So even if the patient is young, such as in 19 years old, we have to screen them, adopt a healthy diet rich in fruits, vegetables, what madam just spoke, whole grains, lean proteins and omega-3 fats, and avoids food high in cholesterol, saturated and trans fat, added sugars and salt. So sugars and also adds to this cholesterol. Engage in physical activity for at least 150 minutes per week. So generally we in clinical practice we advise to go for walking or cycling or swimming 5 days a week. So they can give off to weekends and maintain a healthy weight. So quit smoking and limit alcohol intake. So better to stop alcohol and also quit smoking, and maintaining healthy weight is again and again emphasized, and manage comorbidities. So we discussed largely about diabetes, hypertension, thyroid, kidney, liver diseases, and one should stay compliant with the prescribed medications. So non-compliance to any of the disease and the medications, it leads to it is harmful. So levels of prevention for dyslipidemia, primordial prevention, it is the prevent to development of risk factors that lead to dyslipidemia, such as the same 4 is repeated again and again: unhealthy diet, physical inactivity, obesity and smoking. So primary prevention target individuals with borderline or elevated lipid levels who have not yet developed cardiovascular disease. So persons who are yet to develop cardiovascular disease, we can easily target who has a borderline or elevated lipid levels, and we can do a primary prevention. And in secondary prevention, manage dyslipidemia in individuals with established cardiovascular disease. If a patient already has had a past heart attack, stroke or angina, we should prevent secondary, we should avoid secondary attacks. And tertiary prevention, prevent or limit disability and complication in individuals with advanced cardiovascular consequences of long-standing dyslipidemia. So in any way, our focus should be on prevention. So that is the best option. So this is the common yoga protocol, you all know, and we are not only during yoga day we should be doing it, but on a regular basis we should emphasize it to our patients on a daily basis, and for specific asanas as listed in the SDGs we should advise them so that it becomes a day-to-day practice. So this is the sitting asanas according to the protocol, common yoga protocol, the prone positions, the supine positions. I am not going to in the detail. This is the breathing exercises, what they have given in large in the SDGs. So these are the vegetables to be added. So most of the vegetables are we routinely follow in our day-to-day diet, and whole grains, brown rice is advised, millets are advised, vegetable oils is advised, and as we said, regular exercise for at least 30 minutes a day is best, at least brisk walking for 30 to 45 minutes, and our Sidhha வாழ்வியல் முறைகள், oil bath twice a week, steam bath weekly once, and foods to be avoided: oily foods, fried items and tubers like potato, excessive intake of cooked coconut, groundnut, sesame seeds, milk and milk products, high glycemic index foods. So this high glycemic index foods we should avoid, as well as maida we should avoid. So these are the do's and don'ts. So it's best to drink warm water always and add 3 thoda samapurukal. So it neutralizes the doshas. So our vadiyadalayam, so 3 thoda samapurukal are very much emphasized. Consume low fat, low calorie, high fiber diet, fresh vegetables, whole grains, legumes, greens and citrus fruits, and easy digestible food should be taken, such as rice, double boiled rice, buttermilk, tender coconut water. So include moderate intake of nuts is also advised, include lean proteins and low fat dairy in the diet. So don't avoid fatty meals and late night snacking. So it has now become a common practice in metropolitan cities. We have the food joints all over the night, and we are prone to night snacking, so it should be avoided. Avoid highly processed refined carbohydrate diet, and they are advised to take complex carbohydrates. So this was stressed by our previous speaker also. Limit added sugars, trans fat and refined grains. Avoid deep fried food and junk foods. Avoid overeating or skipping meals. So this is also one thing nowadays we do. So we should avoid overeating and skipping meals. So our வாழ்வியல் முறைகள் காயகற்பம் practices. So காலமே இஞ்சி உண்ண காட்டினார் சூத்திரத்தில், this song we know, and how many of us follow this I don't know, but we should also advise this to our patients to eat in the morning, afternoon and evening, and intermittent fasting. So ஒரு பொழுது இரு பொழுது, so we should advise this and practice at least 45 minutes of moderate physical activity 5 days a week. Silambatam, Malyutham, these were all mentioned in our Sidha literature. Consume food to the level of hunger. So in Marunda Adhigaram, the emphasis on consume food to the level of hunger is emphasized by our Ayyan Thiruvalluvar. So we have to follow that. Consume food only half of stomach, liquids up to quarter of the stomach, and always leave quarter stomach empty. But we never follow this. We keep always eat up to the brim, and a better balance of mood and sleep. So nowadays addiction is one more problem to gadgets, and stress nowadays is a problem. So better balance of mood and sleep is also emphasized. Powder massage, podi thimuthal with the panchakarpa kudiyal podi or kollu churnam or tripala churnam. So this is emphasized. So lifestyle practices, we should avoid daytime sleep or oversleeping, sedentary lifestyle, once again avoid stress, avoid nap after food, avoid high sodium diet, and avoid alcohol and smoking. So in packed foods there's lot of high sodium diet, and also in carbonated drinks that are lot of sugars, that also has to be avoided. So curative interventions, it's for level 1. So it may be in a solo Siddha physician clinic or PHC. So where there are limited resources, we have to recognize signs and symptoms as early as possible, and prevention of complications is mandatory. So clinicians should assess the overall clinical context, including family history and risk factors. That's why more of Siddha physician, family physician approach is always suggested. So you know about the patient and you advise them effectively. And social history such as tobacco use, dietary habits provide valuable insight. And diagnosis is mainly based on fasting lipid profile, and additional tests you may order based on comorbidities and the presentation of the case. So the management, we have to address the root cause of the imbalance, and to normalize the altered or dearranged humors, and revitalization of the 7 fundamental tissues, udal tadus, through detoxification methods followed by internal medications. To apply detoxification methods like ennai kudiyal and purgation therapies, to avoid advise fasting. So complete fasting, intermittent fasting, and oru podudhu, so restricting meals to one specific time a day. Kayakarpam, we already saw that, and medicines with pungent taste are recommended to increase adults, improve digestion, reduce excess IM to balance metabolism. So this comprehensive approach targets both internal and external factors to restore balance and provide overall health. So oil bath we already see, we saw. Arakku thailam is indicated. We can use the sufficient quantity, or according to the comorbidities or the individual constitution, we can tailor-made choose the oil. for oil bath. So the rules we all know, we are using it in our day-to-day clinics. So at least twice a week we should advise the patients, or the first 3 days we can advise the patient. So immediately the patient, the feedback is a positive feedback. If you advise them properly, the patient will come back to us after 3 days and they will give a very good feedback. And Kalichal Marthuvam, so Agasthyar Kodambu is indicated. So we should tailor-made the dose for the patient, and we should also tell about the do's, don'ts, and how to stop in case of excess watery diarrhea. So how to stop it. So and we should advise the patient properly so that we don't lose the patient, but he feels much better after the purgation itself. So that kind of approach we should have. And from day 3, these are some of the drugs which I mentioned based on the STGs. So Nirmulli Kudinir or Nerunjal Kudinir or Sirupulai or Seendil or Kattalai Charu. So Korai Kidangu, so Asok, the Kodampuli, Natai Churi. So these are all we use in day-to-day practice. Whichever is appropriate for the patient and the situation, you can adopt it. And compound formulations, Nirmulli Kudnir, Manduradi Kudnir and Ventamarai Kudnir is best. And Churnam, it can be Karsarangli Churnam or Siraga Churnam, Tiripala Churnam, Tirigadiga Churnam, Nilavagi Churnam, Eladi Churnam or Ventamarai Churnam based on the cases. And Matrai, we can use Vepampu Matrai or Kasturi Matrai. So some of the Varma points based on the STGs are Tivalai Kalam, Purva Varmam, Kaigoli Varmam, Mutira Kalam or Dachinai Kalam. So integrative management is also suggested. So if a case of dyslipidemia is associated with other comorbid conditions, multidisciplinary integrative approach with other medical experts such as with the consultation of diabetologist, endocrinologist and registered nutritionist is essential to achieve a sustained improvement and benefit to the patient. So our goal is benefit to the patient. So we can, there's no harm in referring the patient to a diabetologist or endocrinologist. So this is the recommended diet and lifestyle. So this DASH diet is advised to prevent hypertension, so we can adapt that. And system physical activity such as aerobics we can also advise, and it can enhance cardiorespiratory fitness and ameliorates dyslipidemia. High intensity intermittent aerobic training can reduce myocardial oxygen demand and help control exercise intensity and increase HDL levels. So there's no treatment to increase HDL except exercise. So we can advise that to the patients. And restricted diet and lifestyle, as we have seen earlier, we can avoid consumption of red meat and processed meat, and once again alcohol and smoking is emphasized. And we should also avoid strenuous physical exercise which may trigger cardiac events. So we have come across many events that a patient was doing exercise and he suddenly collapsed. So many known from circles, they were playing sport or also they collapsed because of we should avoid strenuous physical exercises and avoid diet rich in trans fat such as fried food. So these are some of the various research articles so which have documented the benefits of the various diets and the effects of smoking and alcohol consumption on lipid profile. So if you cut down the smoking and alcohol and red meat consumption, cardiovascular diseases and diabetes, it has gone up. So it's a systemic review and meta-analysis, and the association of fried food consumption and cardiovascular risk has increased, and the effect of trans fatty acids on human health. So these are all documented by various PubMed articles. So we should, based on that, we have to advise the patients which is for better. So follow-up is very much important. So, and we should every 14 days, as per the need of the patient, we should offer our support on lifestyle modification, which is the main thing. And referral criteria is again important. So if the patient is not responsive, we should refer, and if there is an evidence of increase in severity or complications, we should refer, and substantial impact on their quality of life and activities in daily living. And if there is a diagnostic uncertainty, and we should refer, and uncontrolled comorbidities. If you give the right treatment also, but the patient is not responding, and there is a associated cardiac disease, please don't hesitate to refer that patient. So this is curative interventions. So same the criteria which applies to level 1 also applies here. Only there is a change of medicine. We should try to recognize the signs and symptoms is vital for the early intervention. It is not about the disease staging, it is only the facility which differs. So it is a small blooded hospital. So the level 1, level 2, level 3 does not indicate the stage of the disease, but it is the care which is matters. And again, social history such as tobacco use and dietary habits we have to monitor, and diagnosis is mainly based on a lipid profile, and we should do the additional test depending upon the presentation of the case. So these are the things which have already we seen earlier, the investigations. And management 2 level, we have added some of the formulations as per the SDGs, and Drachadi Churnam, Nandukal Parpam, Silastu Parpam, Kungliya Parpam, Vengara Parpam, and Varma Martham same as level 1, and recommended diet and lifestyle also same as level 1, and we have to follow up the patients for 14 days or as per their need. And referral criteria, if there is a psychological imbalance, any red flag signs what you have seen earlier, and signs of coronary vascular disease, stroke, TIA or angina, we have to refer them. So again, based on the level 3 curative interventions, so we can do the additional tests like plasma leptin or treadmill test, and we can have these drugs like Mahavasta, Kusmagram or Tangaparpam. So these Chendurams, Anabidi Chenduram, Aganda Chenduram or Vedi Anabidi Chenduram, Purna Chandurdayam, Padigara Chenduram. So the Varma Murtram is same, diet and lifestyle remains the same, and referral criteria we should refer based on morbid obesity, not responding to treatment, uncontrolled hypertension, worsening hypertriglyceridemia, worsening insulin resistance and hyperglycemia, suspected cardiac arrhythmias. So in that case also we have to refer recurrent vascular events and atherosclerotic cardiovascular disease and genetic dyslipidemia, suspected polycythemia, and other modalities can be considered depending on the case to rehabilitate them properly. So conclusion, as we all know, prevention is better than cure. Early detection and regular screening are essential. So many patients, they come to us after going for a master health checkup. So dyslipidemia we detect only during a master health checkup, and we don't order it routinely. And lifestyle modification is the cornerstone of management. Balanced diet, physical activity and weight control are the key. And once again we have to emphasize to avoid smoking, alcohol, and foods rich in trans or saturated fat, and medication adherence improves long-term outcomes. So health is country's wealth. So the future depends on what we do in the present. So be the change that you want to see in the world. Thank you. Next presentation. The overview of my presentation as per the SDGs. So we all know it's a monoarticular disease, and peripheral vadam or viral vadam or amri amila vedidal, and gout is a chronic disease of deposition of monosodium urate crystals, crystal induced arthritis, which forms in the presence of increased urate concentration. So it is characterized by severe pain, redness, tenderness. All the cardinal signs of inflammation are present. So as we are taught from our all cardinal signs of inflammation are present, the joints which occur doing too much uric acid crystal deposits in the joint. So the prevalence, the epidemiology is given. So it is out of 1,000 persons, 3 are affected. So it is more prevalent in men and older women, and with the male female ratio to 7:1, it varies up to 9:1. But in the case of age after 65, the ratio is 3:1. So in after 65 years, the ratio is 3:1. So gout is more commonly in the elderly and to the females. The disease initial presentation is predominantly monoarticular, with the ankle joint being the most common, but the first metatarsophalangeal joint is most affected, affecting over 90% of the cases. So this is the burden of gout in Asian countries. So in Asia, you see there from 77% to 83 per lakh. So 7% there was an increase in the 2021. So due to various factors. So these are the risk factors: hyperuricemia, genetic factors, obesity, hypertriglyceridemia, metabolic syndrome, dietary factors which I have already discussed before, like intake of meat, seafood, what we discussed earlier, sugar sweetened soft drinks and foods in fructose, alcohol consumption, especially beer and hard liquor, increased diuretic use, chronic renal disease, recent surgery or trauma, hypertension, diabetes and menopause. So these are some of the risk factors we should be aware of. And if we consume high purine diet due to it increases the uric acid production. So excessive alcohol, it also impairs uric acid excretion by the kidneys and increases purine breakdown. And fructose, sugar sweetened drinks, it produces purines, increasing uric acid levels. Chronic disease, kidney disease, so damaged kidneys are not able to excrete uric acid. In case of obesity or overweight, it impairs kidney excretion. In case of hypertension, it often coexists with hyperuricemia and a risk factor for gout development. So metabolic syndrome and diabetes mellitus, it is associated with the insulin resistance, which reduces uric acid excretion, and high cell turnover disorders like in case of psoriasis, leukemia and increased cell death. It releases purines, and male sex also, they have naturally higher uric acid levels and more likely to develop gout earlier, and age, it increases with age. So women's risk, as the earlier speaker told, it sharply increase after menopause, and genetics, family history, so inherited predisposition for either overproduction or under excretion of uric acid, so it is also there. And recent surgery or trauma, so physical stress can sometimes trigger an acute gout flare, and dehydration can concentrate uric acid and increasing risk of crystal formation. Lead exposure, they can damage the kidneys, impairing uric acid excretion, and hypouricemia less than 2 milligram, so is not a risk factor of gout, but gout requires crystal formation at high concentration. So it's a nighttime condition, so generally it wakes the patient up, and it results in severe joint pain, And as you know, the big toe is affected, but it can also affect ankles, knees, elbows, wrists and fingers. So with the first to 12 hours after it starts, pain is probably at the worst. So the patient is unable to tolerate, and persistent inflammation, redness and pain in the affected joints with tenderness you can find, and patients lose their range of motion. So the gout worsens. So this is the Sidha pathology based on our incompatible food due to medicines, alcohol, artificial sweetener, toxic food combinations, hyper palatable food, food addiction. So the chart you can follow easily. So differential diagnosis based on the conditions, key features, joint involvement, synovial fluid findings, distinguishing features have been categorized. So pseudo gout, there is it can mimic gout. It is pain is there in the knee, wrist and shoulder. The rhomboid shape, possibly bifringent CPD crystals you can find, and chondrocalcinosis on the X-ray, and septic arthritis, acute, very painful, fever is there, systematic symptoms are there, and usually sometimes monoarticular and very high WBC, positive gram stain culture, systemic toxicity is there and positive culture. So hemarthrosis, sudden after injury, and there is bloody, no crystals, trauma is there, and there is a coagulopathy history. So psoriatic arthritis, patients get affected in the distal interphalangeal joints. There are no crystals. Psoriasis, nail pitting is there, and in ankylosing spondylitis, chronic back pain along with stiffness, axial joints, hips are there, and there are no uric acid crystals, and there is HLA-B27 positive, and in Lyme arthritis, saccharide arthropathy are also some of the differential diagnoses, and followed by that reactive arthritis, and we often encounter more patients with rheumatoid arthritis where we have RA positive with anti-CCC positive, and osteoarthritis patients also. We have the osteophytes and joint space narrowing in the X-rays. So differential diagnosis in Siddha medicine, we have Vada Stronidam, polyarthritis, or Narithalai Vadam, hemoarthrosis, or Karastamba Vadam. It's again a form of peripheral neuritis. Vada Karshanam, numbness due to peripheral neuritis, and Pei Vadam, nephrotic syndrome. So our Yugi Vaidya Sindhamani Padal, and restricted movement, swelling in the affected joint, and the stagnation of blood is mentioned in the song. Karastamba Vadam, so burning sensation, tingling sensation in the skin, and they cannot able to walk. And Vada Kashnam, Sani Padithu Vaitadu Pol Padamengum, so classical case of peripheral neuritis, Kaal Ulaikum and pain, numbness, tingling, prickling, pain. And based on causes of increased uric acid levels, there is hyperuricemia. So we have already discussed, madam has discussed earlier, high purine intake, so red meat, seafood, and organ meats, alcohol consumption, high fructose diet, sweetened foods and soft drinks. So patients, they say if you take soft drinks there is no harm, but there are plenty of harms in the case of metabolic disorders. Increased cell turnover seen in many cancers, chemotherapy, psoriasis, genetic enzyme defects, obesity and metabolic disease, hypoxia or intense exercise, leg toxicity. So in the case of decreased excretion of uric acid, so either increased production or decreased excretion caused hyperuricemia. So in case of chronic kidney disease, drugs reducing uric acid excretion like thiazide diuretics, loop diuretics, low dose aspirin, cyclosporin, and we could come across many patients who are taking anti-tuberculosis drugs. Dehydration, lactic acid acidosis or ketoacidosis, hypertension and renal insufficiency. So mixed or other contributing factors. So there's also increased production of uric acid as well as decreased excretion. So alcohol, insulin resistance, starvation or fasting, toxemia of pregnancy, very rare condition, hypothyroidism and parathyroidism can contribute. So the investigations are the ultimate diagnostic test for gout is detection of urate crystals in fluid from an affected joint, but only a small percentage of patients are subjected to this test, and there are established protocols for clinical diagnosis in the absence of joint aspiration. So the additional tests are, so this is the normal foot and gout in toe, you can find Martel sign. So serum urate concentration. So in acute flare-up, there is a normal levels of uric acid only we can note down in patients. So X-ray, it has a very low sensitivity for diagnosis, but in some cases we have the Martel sign, a protruding salient bone edge separated from a tophus and leaning on it. So ultrasonography, we have the double contour sign, and dual energy CT scan, you have urate crystal deposition with bone erosions, and in complete blood count CBC, we have the if we can exclude myeloproliferative disorders, and raised WBC can indicate septic arthritis, and we all know as ESR is often elevated in all inflammations. Renal function test, hyperuricemia can occur in renal impairment, so it will be helpful to identify that. Fasting lipids, glucose, thyroid function, where hyperlipidemia, diabetes mellitus, hypothyroidism and occasionally hyperthyroidism are associated with gout. Urinary urate excretion, if the serum urate in urine is more than 0.8 to assess, it can be used to assess renal stone risk and differentiate overproduction versus under excretion of urine, and C-reactive protein. So it is typically elevated in acute gout flares and rheumatoid factor to exclude rheumatoid arthritis in differential diagnosis. So this is the diagnostic criteria. So asymptomatic hyperuricemia. So patients do not exhibit any signs or symptoms, and they are typically found by chance. So when their serum uric acid goes beyond 7 mg per dl, so no medicine should be used to address this problem. And acute gout attack, so as we have already, patient awakens from the sleep and severe pain that gets worse at the slightest touch. So even his if his bed sheet touches it, it is or he cannot even wear a socks. So even slightest touch could cause much pain, and the joints become red, shiny and tender, and in intercritical period is also there. Patient is asymptomatic, and even if monosodium urate deposition may continue to increase silently, so we should be on the lookout for it. And chronic tophaceous gout, so it causes joint damage and marked functional impairment. So this is very bad, so we should treat them appropriately. And this is the American College of Rheumatology and the European League Against Rheumatism Collaborative Initiative, gout classification criteria. So based on that, we can score the patient. So the score, how we can score is given in the next slide. So if it is, the score is greater than 8 points out of 23, so we can take it as a gout and treat them appropriately. So based on clinical symptoms, laboratory symptoms and imaging systems, the score is also given in the STGs, so you can follow it easily. So principles is, the first is the prevention and curative interventions, followed by diet and lifestyle. So again, this diet and lifestyle plays a major role for management of gout. So these are the red flag signs. So and if there is uncontrollable pain, joint destruction, constitutional features such as fever, weight loss and malaise. So malaise is unexplained feeling of a vague feeling of not feeling well. So if that is there with the fever and renal failure, so we have to educate the patients what is wrong with them, and they should be educated about the natural course of the disease with possible complications. So therapeutic options need to be discussed along with the dietary restrictions and lifestyle changes such as exercise and weight control that might be helpful for them. So prevention, again, primordial prevention. So we have to adhere to the Terrier Pinia Anuga Vidhi for prevention of disease, that with the help of that we can lead a healthy lifestyle. So prevent development of risk factors like high uric acid, poor diet or metabolic syndrome. Primary prevention, prevent the onset of gout in high risk individuals. For example, if there is a family history and hyperuricemia, we can prevent. And if there is a secondary prevention, prevent recurrence of gout attacks and development of chronic gout. So chronic gout, there will be functional limitation, so we should prevent them. And tertiary prevention, we can manage topicious gout and prevent joint damage or disability. So these are the dietary habits. So three sort of Samapurkal is again emphasized here, and the dash style diet to avoid hypertension. The what not we should avoid deep fried foods, overeating, whatever we saw in dyslipidemia is again emphasized here. So do's, again meditation and physical activity is emphasized, better balance of mood and sleep. So therapeutic purgation once in every 4 months as per our Terrier Pidiadaga Vidhi, regular stress management, maintain ideal weight. So the other don'ts is already we have stressed upon. So level 1, so depending upon the place where the situation where the resources are limited, and level 2, it's a 10 to 20 bedded hospitals with all the basic facilities. So curative interventions is again our based on case to case. We can tailor made the treatment to the individual, not and we can alter the deranged humors and revitalize the 7 fundamental tissues to our Sidhha detoxification methods. So Ennai Kudiyal, so depending upon the patient conditions, we can and the constitution, we can tailor made the oil. Here we have mentioned Arakku Thailam and Sandhanadi Thailam, and for Kalichal Marthum, Kumari Ennai and Siddhadi Ennai. So we can advise them. So and we should ask them to take the necessary precautions and advise them properly. So these are the compound formulations, Neer Mulli Kunnir, Vadasura Kunnir. So we can go for it if fever persists, and Kurudoti Kunnir and Churnam, Paringpatti Churnam, Chindil Churnam and Tirigadu Churnam, Matrai, Vadarachan Matrai, Karupu Vishnu Chakra Matrai, and external application, we know our Sevapakukil Thailam and Vada Kesari Thailam. So this is the recommended diet and lifestyle. So and exercise is also advised. Overweight patients should aim for normal weight, but should not crash diet or follow protein rich diet. So this is emphasized, and patients known to suffer from gout and kidney diseases should be instructed to consume sufficient fluids. So it will prevent urolithiasis as well as gout. So they should be advised to consume 2 liters per day, and adherence to DASH lifestyle, and encourage low fat or non dairy products. So this is the DASH diet. So main goals is to reduce blood pressure, lower LDL cholesterol, prevent heart disease, stroke, diabetes, and support weight management. So its core principles is high in fruits, vegetables, whole grains, low fat dairy, nuts, seeds and legumes. So we should not consume sodium, red processed meat, saturated fat and added sugars. So this is what we should consume. So and the mechanism of action is also mentioned. So it will lead to low fat and we can have a improved lipid profile as well. So that was also was mentioned during dyslipidemia, and also for gout it will be helpful. So we should review periodically. So monitoring the serum uric acid levels are important. So and long term condition, course of the condition. So we should also discuss the person's knowledge of the condition, any concerns they have, their personal preferences and their ability to access the services. So reviewing the effectiveness and tolerability of all treatments and reviewing the comorbidities associated with gout is also important. So this is the level 2 management. So RGM, Divuladi Milagu we know, and Armuga Chenduram, Kalamegana Narayana Chenduram, Purna Chandrodhyam, Linga Chenduram and Ayavira Chenduram. Based on the condition of the patient, we can choose according to the availability and the our experience. And Sangu Parpam, Muthuchipi Parpam, Pavala Parpam, Tanga Parpam and Muthu Parpam is also indicated, and Sulai Kudaram is also indicated, and the following Varma points are also indicated. Kavuli Kalam, Kaimuttu Varmam, Sundigai Kalam, Kal Nerukku Varmam, Virutti Kalam, Ullangal Vellai Varmam, Komberi Kalam, Uppukutri Varmam, Mudichu Varmam and Modi Viralgai. So external therapy is also indicated. So antiviral therapy twice a week on the swollen areas. Poultice Moosambara Petru, you all know, Kalarchi Patru, Avarai Ulundu Patru, Kavikal Patru, Ambukra Kerangu Podi Patru, and we can also use Perandai with the juice of Erukku and apply as a compress. Poochu we can also use Ulundu Thailam, Medugu Thailam, Karpuradi Thailam, Vadakesri Thailam. We can also apply Kunguli Vennai, and as well as we can apply Pinda Thailam and Maina Thailam. So referral criteria is uncontrollable pain and no response to treatment. So this is the main referral criteria. Joint restriction, if there is a joint restriction, we should refer. High fever, weight loss and malaise, a rise in serum creatinine and serum urea above normal limits, suspected cardiovascular complications. So it is possible due to gout, so we have to avoid, refer, and patients taking chemotherapy for neoplastic diseases, uncontrolled comorbidities, evidence of increase in severity complications, diagnostic uncertainty, substantial impact on the quality of life and activities of daily living. So follow up diet and lifestyle, and we can follow up once in 7 days or as needed. So this is the take home message. Eat smart, stay light, adopt a low purine, DASH style diet, ensure adequate hydration and balanced nutrition, maintain healthy